Hello everyone. Welcome to the Affinia Healthcare Leadership Academy. I'm very pleased that you're here. Today is our first installment of 19, and we will go from this date, July the 9th of 2019, all the way through April of next year. So there will be 19 opportunities. As we'll learn this afternoon, people who complete this process will be certificated through Affinia Healthcare, and we're searching with the help of Donna Andrews and Gwenita Watson for universities in the area that might also offer a certificate for the completion of this program. My hope is to broaden and expand leadership and management knowledge about healthcare services. We will have a couple of days, the first 2 days in fact, that are specific to our type of environment, the Community Health Center. The other 17 will be generalized to the larger health services environment. So it's quite a lot of information. Each and every session will be no longer than 90 minutes. It's possible that we could go 60 or so. That's probably more the norm than 90, but just know that we will keep it within 90 minutes. All of these sessions will be filmed and recorded and placed on our intranet. And you will have access, if you're taking part by internet, to our PowerPoint slide deck. So that sort of gets us started. The introductory session is an introduction to community health centers, or as I've called it, CHC 101. A bit more about our academy as we start today. We'll talk about a history of the community health center movement that goes back to the mid-1960s and even before. Community health center facts as they relate to what community health centers across the country are required to do, the regulatory requirements, and what we do to serve the needs of our patients. And then program eligibility, just briefly here today, as during our second session we will talk about regulation, HRSA, and the agency that controls the grant funding for community health centers. So that's next time. I think that's July the 23rd. And then we'll have time for questions and answers at the end. Also, as we go along today, if you have a particular question or comment, don't hesitate just to get my attention, and we will take those as they come. 30 or 40 minutes into the session, we'll probably take just a brief break to help the technical facility of getting the recording accomplished. Okay? We good with that? Everybody?
Yeah.
Good. Thank you. Again, so happy that you're here. The series is open to all of our staff, and in fact, one of our board members is here today. Deborah has joined us to take part and is watching on. It's intended, as I mentioned earlier, to broaden our understanding of various topics related to management and leadership in health services. Your participation, is voluntary and it's free of charge, no cost to you at all. It is necessary to be, if you are on site, as you know, it's necessary that you have your supervisor's approval, because what's most important is getting the work done in our departments. If you can't be here or choose not to be here and want to participate, then you will have access over our intranet as promised. Topical information will be accessed from the American College of Healthcare Executives, the National Association of Community Health Centers, and other credible sources. In other words, I won't be going to Wiki for anything. I won't be looking anywhere. I'll be looking only at the credible sources of information for health services, management, and leadership. And hopefully you will find that of value. Here is a list. You will also find it in the slide deck, but a list of the particular topics. Again, today is this introduction to CHCs. Next time, regulatory compliance and the agencies that govern. We'll go over health in society, the delivery of health services in the U.S. and policy, social determinants of health, which are particularly important in areas such as the one we serve here in St. Louis, the external and internal environments to healthcare, Mission and governance and vision and strategy will be divided in two different sessions, talking about our directional strategies in healthcare services. Common leadership and management competencies. Again, keeping this general. I want to stay out of the weeds unless there are particular questions, but we will talk about the competencies that we understand to be important in both management and leadership. Professionalism, quality improvement, and performance measurement. The human resource and finance functions. Again, once more, we are going to stay out of the weeds. So we're not going to go into the balance sheet and learn all of that stuff, and we're going to stay out of the particulars of human resources, but we are going to cover the high points to give the audience a general overview. The same with information technologies. Number 18, communication and branding and public awareness is a topic we will cover. And then finally, in April of 2020, leadership of organization development and change. That will be our final session in this series of 19. Okay? Everybody ready? All teed up?
Yes, sir.
All right, great. Well, here we go. There's a really interesting story. I think it's a great story about how community health centers started in the United States. Listen closely. There's a guy named Jack Geiger. Jack in 1957 was a medical student at Case Western, a senior. Jack had quite a future in store, and little did he know that it was going to really begin for him in Africa. The Rockefeller Foundation had a scholarship, and Jack Geiger applied, and he earned the right to go for 4 months to Africa and spend time with two physicians there, doctors Emily and Sidney Kark. So Emily and Sidney Kark, I'm not sure where they were trained in the world. I'm sorry that I don't. I should know that. But anyway, they had been in Africa for a while. In fact, they had helped to begin 45 clinics. And these clinics were later to be called community health center locations. Not just where a physician and a nurse or a dentist or a psychologist would see a patient in an exam space, but the idea is around community-oriented care, taking into consideration things like water, the quality of your water, your housing, having access to nutritious foods. So when Jack arrived, he was allowed to spend some time on a tribal reserve, and this tribal reserve is in the Zulu, and also at a place called Lamontville, which is a small community of fewer than 10,000, where there was one of these 45 sites. And his life was changed. He realized that there was something really significant going on in South Africa. And he wasn't sure why just yet, but he knew it was important for his life. 4 months there. Fast forward now to 1964. Jack Geiger had completed his medical residency, and he was at Harvard. In that summer of 1964, which many of you will recall is Freedom Summer, he worked with a group of about 30 people to come up with a group to go to the South and to help provide medical support for people who were there during the civil rights struggle. He did that, spent some months there with a group of 30 doing just that, providing medical support. In December of 1964, the Delta Ministry of the National Council of Churches held a briefing to talk about and learn about what had happened that summer. At that briefing, Dr. Geiger met a gentleman named Count Gibson. Dr. Gibson was Director of Preventive Health for Tufts University. In fact, as fate would have it, these two physicians were on the same flight back to Washington, D.C., and they sat together. And they talked about their experiences, and they learned that both of them had an idea, and both of them had concern and compassion for health care for people in underserved communities. So one of them asked the other, what do we do next? And Dr. Gibson says, well, you know what? I know somebody who works in the Office of Economic Opportunity. He's the Director of Research and Development. His name is Sanford Kravitz. Sanford Kravitz. Let's go see Sanford Kravitz. So that's exactly what they did. And they had a plan. They were going to go in and see Sanford Kravitz, and they were going to ask for $30,000 for a feasibility study. Now here's another piece of this puzzle. I find it to be really fascinating. The head of the Office of Economic Opportunity, to whom Kravitz reported, was a gentleman named Robert Sargent Shriver. Sargent Shriver was married to a sister to the late President Kennedy and the new Senator Ted Kennedy. Isn't this interesting? Really interesting. So they had their meeting with Sanford Kravitz. And as it goes, as I've read, Dr. Geiger said, you know, what we need is $30,000 and a feasibility study. Would you do that? And Mr. Kravitz said, no. In return, Dr. Geiger said, well, what do you mean by no? We really need this. He said, well, what we're going to do is give you $300,000 and just go out there and do it, which gave them the impetus then to decide what to do next. Shriver was all about this, very supportive, compassionate in nature. They also knew that there was going to be a huge hurdle. At the time, a group that was basically known as the Southern Senators, the Southern Governors, and the medical machinery, if you will, in all of the South weren't at all interested in government intervention in health care. Not at all interested. They didn't want to see the government playing a role. They thought it would be, quote unquote, socialized medicine. So there needed to be a way to keep those political influences at bay, if you will, and to move forward in a way that could help support care. So Dr. Geiger and those 30 others from that group had been in Mississippi. And so the decision was made to choose Mount Bayou, Mississippi, and then also, I think this is also interesting in this neat story, Columbia Point, Massachusetts. One might ask, why Columbia Point, Massachusetts? Well, it's not far from where the Kennedys had their stronghold. And Ted Kennedy was a very strong supporter of this kind of development. In fact, as a new senator, Senator Ted Kennedy wanted health care to be his primary platform. You put all these pieces together, and 2 community health centers were started, one in Mississippi, one in Massachusetts. And a few months later, after they had gotten their legs and things started to develop, then Senator Kennedy worked with Jack Geiger after a day together over a dinner to put together legislation to create the Office of Health Affairs in the OEO, or the Office of Economic Opportunity, under Shriver. And federal legislation in 1965 made its way through Congress. The president signed it, and we had then what is now known as the Community Health Center movement in the United States. Elma.
Mount Bayou, Mississippi. Why
Yeah.
did you choose Mount Bayou, Mississippi? That's kind of close to where I was born, down in Greenville, Mississippi.
You were born in Greenville, Mississippi, okay.
And Mount Bayou is only about 8 to 10 blocks long. It's not very big.
Not very big.
And they chose that particular county to put that center there.
Well, everybody heard the question. All of you in the back there. Elma, you were born right there near where this all took place.
Yeah.
Gosh. Well, I don't know for sure, except to say that a lot of the struggle was occurring in Mississippi, and this group of 30 went to Mississippi to provide their medical support. And it was just a place where, while difficult, certainly difficult politically, it was a place where Dr. Geiger and Dr. Gibson and others felt there could be this startup to take place. I don't have a better reason than that, but it is interesting that you have that background. Isn't that cool? I tell you, that's very cool. So community health centers today, I'll get to how many we have going forward. You will find on your slide deck these bullet points that sort of are background to the description that I've given you for what I believe is a wonderful story for how something really important happened in the United States. And it started with the thinking of a medical student, a senior, 1957, who went to South Africa on a 4-month grant to enhance his experience, and his world was changed. I've never met Dr. Geiger. I've been in a room where he spoke. It was a room of 3,000 people or something, and I didn't take time to stand in line to shake his hand. I'm sorry that I didn't. One day I might, but Dr. Geiger was a pioneer for what we do in community health and a very important figure in the landscape of health services delivery in the United States, especially for people in low-income circumstances, people who have barriers to access to healthcare delivery. And that's why we do what we do at Affinia Healthcare. Charlotte.
So before this started, so lower income families did not have access to health care at all?
So the question is, did low-income families have access to health care before then? So a little more history. Medicare and Medicaid were enacted in the same year and became federal law in the mid-1960s. So prior to that time, there was kind of one insurance company in the entire United States, Blue Cross and Blue Shield, for people who could afford it or employers that provided it. Everyone else, their responsibility was to find health care, barter for it, buy it with what resources that they have, or go without in the United States. Now there was a 50-year period between 1910 and 1965, 45-year period. Yes, Janet, 45, not 50. But you'll see that there was a 45-year period where there were other kinds of developments. We'll talk about that in another session that are kind of interesting in the United States. But it wasn't until the mid-1960s that the federal government truly got into the provision of health care for senior citizens and people in low-income circumstances who are uninsured. Also interesting, huh? In the history of management and leadership, I'll cover this in a few months, but the 1960s were also an interesting period of time. We shifted our thinking and our assumptions about management and leadership very significantly in the 1960s. So a very important period in the history of the United States. A civil rights leader, icon, was murdered, a president was murdered, an attorney general was murdered. Just a very, very difficult time. And a lot of new thinking occurred and new assumptions from the past were challenged in the 1960s. And this is one of the reasons, I'm sure, that we have community health center model in the United States, that the country's political leaders were prepared, were ready to help make change. And the public at large, the outcry for it. Does that make sense? Okay. Yeah. Thank you for the question. Thank you both for those good questions. Okay, what is a community health center? What is community-oriented primary care? This is the bedrock. This is why we do what we do. This is what Emily and Sidney Kark, the doctors in South Africa, were thinking. What is the difference between community-oriented primary care and what we might otherwise do in just providing health services in a community? Well, it is the provision of comprehensive primary and preventive health care in the community setting. Also, it's the putting together of, the melding of population health principles with the practice of clinical medicine. We want evidence-based medicine in community-based settings. And again, I go back to my earlier description, how clear and clean is your water? Do you have a safe place to sleep and live? Is your food nutritious? Do you have immunizations for your children? What's the status of your oral health? So many things like that that are key to community-oriented primary care. In my library, in my credenza in my office, and the books we keep at home, I could share with you, if you'd like, a book or two on this topic of community-oriented primary care. It might not be quite as interesting as Jack Geiger's story, but it will explain to you how it is we do what we do in the community health center environment. Okay? Everybody good?
Yes, sir.
All right. The federal law that came about in 1964-1965 is under the Public Health Services Act, Sections 329 and 330. Sections 329 and 330 of the Public Health Services Act. And there are six areas, six divisions, if you will, under this particular law. One is to fund community health centers. Another is to fund migrant health centers. A third is for health care for the homeless. School-based services is a fourth. Then there's public housing, and the sixth is special populations. And today we denote this as for AIDS and HIV. So Affinia Healthcare, as a community health center, we have grant funding through the CHC, Community Health Center line item, through the health care for the homeless, and for public housing. I would also say that we're giving some consideration to school-based services. We are in 3 schools now, and considering whether, if grants become available, whether we would be a fitting applicant. So it's quite likely that we will think about that. But you'll see that Affinia Healthcare, our organization, is very actively involved in 3 of these 6 divisions of federal law that came about through amendments to the Public Health Service Act, Sections 329 and 330 in the mid-1960s. Okay? Under the regulations and the HRSA review and the agencies on July the 23rd, I think, which is our second session, we'll talk about that in more depth. All right? Good? Here are some facts about community health centers. Let me first begin at Affinia Healthcare to say that about 21% of our total sources of funding come through these 2 sections, 329 and 330. The rest comes from reimbursements through insurance companies and Medicaid reimbursement and the amounts that patients pay to cover their fiscal responsibility for the care that they receive and other kinds of grants. So 21%. We are a mature community health center, meaning we've been around many decades. In organizations that are new to community health centers, a higher percentage, a higher proportion of their total sources of revenue would come from the grant. In fact, the federal grant. In fact, many community health centers start and the only source of their revenue is the federal grant. It's not unusual in the country for this to be the case. But the longer an organization has been around, the more mature it becomes more diverse, seeks other types of revenue sources to serve the mission of the organization. So ours is 21% of our total sources of cash. I mentioned that for a couple of reasons. It's important to note. Second is to kind of look at the law and the regulation on its face. The laws under the federal government govern everything we do that's in scope. If we have identified a location or a service that is covered by the grant, then everything in that service or location is governed by the statute and the regulations that serve the community health center law. So for an organization like ours, then, even though only 21% of the total sources of cash comes from the grant, about everything we do, since nothing we do is out of scope, is covered under the regulation. So it's a significant reach of federal authority into our nonprofit organization. And that's because we apply to be a federal grantee, and so that we can serve better the needs of people who need it, especially the uninsured and low-income individuals. Does that make sense to everyone?
Yes.
Okay. CHCs must be open to all patients. This is vitally important, regardless of ability to pay, and offer a sliding fee scale based on household income. This sliding fee scale is approved annually by our board of directors. Here I'll stop just for a moment to say I'll come back to governance and the board of directors on July the 23rd. So hold that thought, but it's coming. I'll talk a great deal more about the board. I report to a board of directors. The board of directors hires the CEO. The board of directors is responsible for the services provided by our organization. The ability to pay means whether or not you can based upon your household income. Let me differentiate ability to pay from willingness to pay. A person who has the financial ability to pay and chooses not to is billed. We expect to be paid in the same fashion as we would in any other type of business. If their ability to pay is challenged based upon their household income, then that individual, those people are eligible for our sliding fee scale. And so we watch that very closely. It's part of the federal law, a very important aspect of what we do. Community health centers disproportionately serve more low-income, uninsured, and Medicaid patients than any other provider segment. In a later slide, we'll have some data to share with you about that. For Affinia Healthcare, about 95% of our patients have household incomes under 100% of the federal poverty level. Across the country, it's a different statistic, and the measure is at 200%. We'll see that a little bit later. But the point that I hope to make here that resonates with Affinia Healthcare staff is that we really are a community health center that meets the spirit and intent of the federal law, because a very large percentage of our patients are in low-income situations and are uninsured. So that helps us to feel much more enlightened, feel better about what we do every day. It does me. 90% of community health center patients have household incomes under 200% of the federal poverty level. If I'd read that before I said that earlier part, then that would have taken less time. I'm sorry for those of you who are listening on the, over the internet. But anyway, let's move on. Community health centers provide access to high-quality, affordable health care and improve health outcomes in underserved areas. Again, next week and the weeks that follow, 2 weeks and the weeks that follow, I will accentuate this. In order to be an applicant that is successful with the federal government, you have to prove that you're in a medically underserved area, serving a medically underserved population where access to care has barriers. You have to provide certain demographic statistics that support your grant application. So it's important under the federal guidance that community health centers provide access to high quality, affordable health care, medical, dental, mental health, pharmacy enabling services, either by providing those services directly or through an arrangement, a contract arrangement, and improve health outcomes in underserved areas. CHCs are community-based, locally driven, nonprofit health systems designed to solve access and disparity problems at the local level and focus on improving health for all. That's everyone. So 2 points to make here, I think, of relevance. One is that the governing board is made up of our community, and the governing board of a community health center must be governed by a majority of patients. So it has to be a patient majority, a consumer majority. So if you have 19 members on your board, one more than half of that group would be 10. 10 of your members must be patients of your facility. If your governing body is 11 in size, your bylaws say 11, then at least 6 of those board members must be patients of your community health center. So that's very, very important to note. Any questions about that?
Actually, Alan.
Yes, Donna.
What is the difference between a federally qualified health center, one with that FQHC designation.
Ah.
And then the community health centers that are just straight, you know, without that designation, are they still providing the same services as an FQHC?
Well, that's a great question. Donna Andrews asks what an FQHC is and how that relates to what a community health center is. So let me try to answer that. A community health center is known under federal law back to the mid-1960s just as that. It's identified as a community health center. Many organizations these days across the country also use the terms community health center even when they are not community health centers under the grant. So for example, St. Louis County Health Department refers to its organizations, its primary care entities as community health centers. And it can, there's no reason why that it can't. But a community health center under federal law, Section 330 of the Public Health Service Act, that's an organization that's a community health center receiving grant funding. Now, you ask about an FQHC. That's Federally Qualified Health Center. It's new language from the late 1980s, early 1990s, when Congress changed Medicare law to allow a certain all-inclusive rate to be paid to community health centers for Medicare beneficiaries. So Medicare, people age 65 and older and who qualify otherwise based on a couple of things, end-stage renal disease, or if they are in some way physically or mentally disabled. A person under the age of 65 can qualify for Medicare. Otherwise, you have to be 65 and older. So it's Medicare regulation, Medicare law, that created the acronym FQHC. So today, as many of you know, if not most of you, I spend some time in Jefferson City. I spend some time in Washington, D.C. for the Missouri Primary Care Association and primarily for Affinia Healthcare to educate, advocate with the people we elect to be in charge. And so I often hear FQHC before I hear community health center. But the law says community health center, the initial law from the mid-1960s. So I hope that gets it. Is that good?
Perfect.
You all good?
Yeah.
All right. So we've gotten through those CHC facts. We're going to take just a momentary break to help the technology to assure that we get all this recorded properly. So I'll be right back. All right. Any other questions or comments before I go to the next section?
Well, I have.
Charlotte.
I have one. I never heard, I didn't hear you use the word clinic.
Clinic?
Isn't the clinic like the CHCs?
Okay.
Health centers, and so is there a difference or, you know?
Another great question. So the question that Charlotte poses is this a clinic? We've always heard of the name clinic and that I never refer to our organization as a clinic. So first is to say that most primary care entities in the country are referred to as a clinic. Clinic is generally known as a place where you go and you get medical or dental or behavioral health services from a licensed, qualified provider who's supported by other people who are licensed and qualified. In the community health center movement, the idea of clinic has kind of a negative connotation, and that's because community health center as a term, a set of terms, is a much broader array of services, of social supports, of enabling services, of help with your application or getting you connected into the broader network where people can get help. Generally, when you go to your physician's office, like I did when I was growing up, I didn't have a direct connection with those services in the community. In a community health center, that's the whole idea of community-oriented primary care. Not only are you getting dental and behavioral health and mental health and medical services of a wide variety in most locations, you're also getting help with other aspects that relate to the social determinants of health. So some people in the movement have a particular interest in this. It doesn't get me all riled up too quickly, but some people will go on the mat with you to say, we're not a clinic, we are a community health center, and they're very clear, because that's what they think, that's their belief. Does that help?
Yeah, that helps, because clinics, I don't think, were patients who had insurance, did they go to clinics
Yes?
back then too? Okay.
Right, right. Depends on our perception of what clinic means. You know, I grew up in a rural area. Many of you have grown up in urban areas. So, you know, clinic means something different in different places, just like FQHC means something in different places. And it will mean something different in different parts of the country.
And clinic in the city,
Uh-huh.
here, like Charlotte's saying, to us that meant free.
Oh, okay, yes.
Clinic, you going to the
Right.
clinic,
Yes.
you're going to the free clinic.
Right,
So
that's
that's
why I was
where we
asking
get that.
about free insurance.
Well, that's another theme, so thank you. Let's go down this for a moment, because that's also pretty important. Alma is saying the idea of clinic automatically took most people in St. Louis to the thought of a free
Yes.
clinic. So,
And sir, let me
Yes.
just jump in right here.
Please,
To
Donna, yes.
piggyback on Ms. Alma, what she's saying,
uh-huh,
you know, that is terms of, because we always talk about high quality care.
yes.
And does this mean, is this probably the reason why there's a stigma attached to community health centers for not providing
Mhm.
quality care?
Mhm.
Is because people think we're free clinics?
Yes.
So there's a stigma associated with primary care delivered in community health centers, is what you're saying, and maybe the reason is this idea of free clinic.
Exactly.
So yes, that is true. That stigma exists. And to properly address this question, I'm going to have to take a departure for a couple of minutes into a further look at our history. Back in the mid-1800s, about 1847 in fact, the American Medical Association was formed, and one of its reasons for being formed was to help deflect this idea of government intervention into healthcare delivery. That's not the main reason the AMA exists, but it's one of the reasons that it came into being. Physicians want to be in control and deserve to be in control of the services that they provide based upon their state-endowed license, their state-approved license. And physicians are at the apex. They're at the top of thinking for healthcare delivery. I'm thinking only the medical side here, of course. There are dentists, there are psychologists, but you get the idea. And the point here is that there is a fear in our country, in this capitalist society. There's a fear of government intervention into the delivery of health care. So as a result of this fear, we see lots of conversation these days about any entity that's perceived as being related to the government involved in the delivery of the direct provision of health services. Now, have there been times when community health centers in the country were providing a substandard level of care? And I'm speaking of individual ones, not the overall landscape, but individual community health centers? Probably. I will say to you that at Affinia Healthcare, I'm very proud of the quality that we demonstrate and prove. Medical, dental, behavioral health, the enabling services, we provide a very high quality of service from people who are trained in the best institutions in the country. So we're not stigmatized by this. We may feel it occasionally because other entities want to say to Affinia Healthcare, well, you're providing services in areas where poor people live, so therefore the standard must be lower. No, not true. So that free clinic and the Homer G. Phillips from 50, 60, 70 years ago, right, Alma?
That's correct.
Right? So that's where we are today, and we know that at Affinia Healthcare, we're doing a marvelous job providing high quality care and services. It's an important point, everyone, to expose and to put on the table and to talk about. And that's the stigmas that exist and started in the 1960s when some people really didn't want government to be involved in this. And those thought processes still remain in some areas of the country. Hope that answered these. It's a very good set of questions. I hope we covered those. Are there any others before we go on? Yes, Alma.
Just saying that we have come a long way.
Yes.
And where do Affinia rank? Are we the largest, the smallest, or we're in the middle?
Okay, so in the state of Missouri, for
Yes,
example?
state of Missouri.
So there are 1,400. Great question. You've been looking ahead, haven't you?
I've been looking at
Doing your homework.
I'm reading.
Yeah. Approximately 1,400 community health centers with 98 locations across the United States. This was through 2018. There are 29 community health centers in Missouri. Our organization ranks in the top 3 in total size. There's one in Kansas City and one in Southwest Missouri that both see a greater number of unique patients a year. They're in different environments. We have 4 community health centers in St. Louis. All of those 4 work in the rather limited pie. In other words, it's a St. Louis City and the region there. We do have patients from outside of St. Louis region, but I hope you understand what I'm saying. We are within a certain region, and there are 4 community health centers serving it. Yet, ours is the one that serves the largest number of uninsured patients in the state. So we're among the top 3 largest, and our organization serves the largest number of uninsured patients of any of the 29 in Missouri. Did that answer your question?
Yes.
It's more about our mission, isn't it?
Yes, it is.
Right? And what we do to exist to serve people that we have the privilege to serve. In 2018, 28 million U.S. residents were patients of community health centers. About 25% of the uninsured residents were among that group, and 15% of Medicaid enrollees in the United States. So you see, we've gone from being a cottage industry. In 1965, there were 2, Mount Bayou, Mississippi, and Columbia Point, Massachusetts, 2. Today, there are about 1,400. And in those organizations, community health centers serve 25% of the uninsured residents in the country and about 15% of the Medicaid enrollees. In 18, Missouri's 29 community health centers were the medical home, patient-centered health home for 566,000 patients and provided more than 2 million encounters for the state of Missouri. Okay? Yeah. Community health centers are then kind of a slide to wrap this up, 2 or 3 statements of purpose. We are providers of choice for our patients. We are deliverers of comprehensive, high-quality care. We remove barriers that impede access. We are encouragers of community leadership in the development and provision of their care. And we're of the community, not just in it. We didn't just come into the community to add or even to take, but our governance is a patient majority. The majority of our staff members come from within the communities, so we're of the community, not just in it. Just briefly, this last slide, this is a precursor to what we will talk about in our next session. Regulatory guidance, regulatory control, the agencies that do that, the things that we are expected to do as a community health center. You can be a private entity or a public agency. I know of an organization in Kansas, for example, that is a county health department that operates a community health center organization. So you can be one of those. You must be nonprofit or a public agency. You can also be a tribal or, follow this along, an urban Indian organization, or a look-alike designation. So before I get that question, I know it will come up, but a look-alike is an organization that follows all the regulations but is not yet receiving the reimbursement advantages the fiscal advantages of being a grantee. In other words, there's no reimbursement, no grant money yet related specifically to what an FQHC or a community health center can earn. So these organizations, nonprofit organizations, often begin as a look-alike. Then they are tested to see if they meet the regulation. Then they make a request for the funding through an application process, and then they earn the right to be reimbursed in the way that FQHCs and community health centers are. That's how that process works. And a good example is Fordland, Missouri. For a few years was a look-alike, and it's now a full-fledged community health center. The grant application process is competitive. Every 3 years, we have a new service area competition. Other nonprofit organizations could compete for our grant. Sometimes this happens in the country when one organization thinks we can do that differently or even better, and so they apply for the same funding that another organization is receiving. Wouldn't that be interesting? Right? I mean, we kind of wouldn't want that. Right? But every 3 years, this can happen for any community health center, and so it kind of keeps us on our toes, right? Like the Joint Commission does, and right? Yeah. We submit that. The application must be approved by our governing body. Remember, the CEO reports to a governing body. Governing body sets policy. Hold that thought. We'll talk about that more next time. And there's a notice of grant award and an approval for project implementation. All of this is very technical. It comes out of the federal government. They tell you exactly what you can do and when you can do it as it relates to the grant. Okay? Any other questions? Great questions today. Great. Anything at all? Well, listen, I want to thank all of you for our first session. We've wrapped it up. It's kind of finished, and we'll see you session 2. I think the date's July the 23rd. Thank you all very much.
Thank you.
Yeah, you're welcome.
job.
Yeah, okay.
Yeah.